case for monitoring. Now, here's my conflicts, not as long a list as Charlotte's. As Matthew kindly mentioned at the beginning, this is my regular home. This is the clinical trials unit at the Christie Hospital. And this is where I spend most of my week looking after patients in clinical trials. And when we were discussing this debate yesterday over dinner, my learned colleague, Jam, in Oxford, said that I was the least obvious choice to defend the position of waiting until clinical relapse due to the fact that I do clinical trials. Now, I don't know what he meant. I can only assume he thinks that I view every patient as a guinea pig. Just wait, and I'm just keen to get them into that clinical trial as quickly as possible. But in the coming slides, I will convince you that not intervening early is the right thing to do. And that's because it's not based on evidence, whatever Charlotte and all her trying to bamboozle you with science try to claim. It's financially irresponsible, and it might harm the patient. So I knew that Charlotte was going to wheel out this paper. And it does sound, it sounds impressive, doesn't it? Look at the key points here. Patients with multiple myeloma after clinical progression have inferior survival compared to patients with multiple myeloma after biochemical progression. And these, if I was a patient reading this paper, I'd be really alarmed. Median survival, 60 months. In those with biochemical progression being treated versus 26.2 months in those with clinical progression. But I would make the point that Charlotte is muddling up her chickens and her eggs. What do we know about patients with clinical progression as their first presenting feature, their first indication to treatment? Well, they probably have a more aggressive disease phenotype. And so all that Charlotte is telling me is that patients with an easier to treat myeloma may respond better to intervening in their therapy. And I spent a long time arguing this point with a medical monitor for one of my clinical trials. Here's the inclusion criteria. As Charlotte pointed out, a lot of our clinical trials put this huge emphasis on biochemical progression. And some of you who are in the audience who don't spend as much time battling with medical monitors as me will be very surprised to hear that, in fact, clinical progression no longer counts. So we were discussing a patient who had broken through his current line of therapy with malignant hypercalcemia, had to be rescued with some high-dose steroids and other treatment, not eligible for the clinical trial because he's only got a modest rise in his urinary free light chains. Therefore, apparently, his myeloma has not progressed. And if we look at all of the seminal studies, and I don't expect you to read all of this, that has really, forms the framework for the treatments that we use. What we discover is if we look at the percentage of patients with biochemical progression compared to clinical progression, well, we can't actually see what those proportions are. Now, I've already told you that clinical trials have a propensity to only enroll biochemical progression, but the comparison is not possible. So the column on the right here is percentage of patients with biochemical relapse, unknown, 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 unknown. This makes the point again. So why is it that in none of these clinical trials that inform what we do, anyone is willing to look at the differences in how patients get on, depending on whether they have biochemical relapse or clinical relapse? Well, I'm not a conspiracy theorist, but this might be one argument. So it's not really in the interests of the pharmaceutical companies to demonstrate that we need to use their drugs later. And I've got a very similar slide to Charlotte in my slide deck here. Charlotte is an extremely capable clinician and scientist. I'm not sure about her predictive powers, apart from guessing what might have been in my slide deck. But if I can take you back to the patient, we always have to think about the patient in these cases, don't we? And it's all about an individualized approach. So when his myeloma was symptomatic, he had kappa light chains, involved light chains of over 8,000. He's just miles off. Do we seriously think that we should intervene at this time point? And those two papers that Charlotte also quoted that look specifically at patients relapsing after frontline autograft, both bone marrow transplantation papers, recognized that the median time between biochemical and clinical relapse is 5 to 6 months, and a quarter of patients with biochemical relapse do not show symptomatic progression after 2 years. And can I also remind you all that, as Neil's already showed you in his talk, the thing that drives progress and drives our improvements in outcomes in multiple myeloma is the development of novel agents. So Charlotte is basically proposing that you give an already outdated treatment to this patient rather than waiting a couple of years and having something better to offer. So for the horticulturally minded in the audience, does anyone know what this is? Anyone? This is a money tree. Now, they're a very beautiful houseplant. I believe that, it's felt that if you put them in your home, in your office, then, it will bring in good luck and fortune. But they don't actually grow money. And as we all know, the £350 million a week additional NHS funding that we were promised by our Prime Minister at the time, Boris Johnson, hasn't materialised. And, these are expensive drugs. I don't know what Charlotte had in mind for this outdated therapy Charlotte had in mind for this patient. But, daratumumab, £4,320 a dose, and you're going to give that weekly. Bortezomib, we all think this is cheap now because its patent is finished, but it's still £500 a dose, and Charlotte's presumably going to give that once or twice a week. I've left the decks off. We'll let her have that one for free. So, and then, of course, let's consider if we are proposing that this patient needs to be exposed to daratumumab and Velcade. Let's revisit the New England Journal of Medicine paper that introduced this as a standard of care treatment. Grade 3 to 4 reverse events, 76.1% of patients. Now, I spend a lot of time with my nose buried in the CTCAE grading system, and let me remind you that means these patients might need to be hospitalised. This is not what we want for this man, who is currently living quite happily in the community, not on any treatment. And death was reported in 5%. Now, I'm a big fan of a visual abstract. So here, as promised to Charlotte last night, are my 4 pictures to remind you why this man does not require treatment. Thank you very much.
Actually, if you want to come and join us up here for any questions we have, just before we do the voting again. You have to vote first? All right, we can vote first, I don't mind. Can you vote first? Okay, let's vote first, before anyone gets any more biases, because actually I want to ask some questions which might bias things. So let's go back to the question again. So it's just about to come on the screen. So yeah, if you want to log back in again and then see if your answers have been influenced at all by the debate. So just to remind, what's the option now? This is someone relapsing 3 years post-auto with biochemical progression. So start second-line treatment now. You would have started it already. Repeat the marrow and genetics or close observation and further imaging. A couple of people just changed their mind, but okay, I think we'll stop there, and we'll see what the results show.
Not much changed the mind at all.
So it hasn't hugely changed, but I think actually more people are. So slightly more are doing close observation. I think that was about 50% before, wasn't it? So it has gone down slightly in terms of the interventions, either imaging, either bone marrow or starting treatment now. Okay, let's give you a chance to answer any questions. Particularly the one I want to ask is about you both presented the same data and interpreted it differently, which is obviously commonly the case. You mentioned, Charlotte, about the lead time. In that study, and I haven't looked at it in detail myself, did they go back and look at the patients who they classified as having symptomatic disease? Did they go back and look at when they had biochemical progression? Because that would be the true answer, if you see what I mean. So obviously Emma said the median is 6 months or whatever, but did they actually look on the individual basis what their historical results were?
No, because I think that in most of the cases that occurred at the same time, I think for the patients with clinical progression, from memory, unless Emma remembers differently.
Because in a way, that's the randomised study that needs to take place, is actually at the time of biochemical progression, making a randomised decision, option.
That is the problem with that study. So the patient numbers look impressive. It's over 1,300 patients, but it's retrospective, and the decision's been made.
Yeah.
Like, these patients have already been treated or not treated, so it doesn't move us any further forward.
Any other questions? Gui.
I think Charlotte deserves a word on her side, really.
Thanks.
So I used to think that we should wait, and I've been always very conservative about sitting on biochemical relapse, and partly because many patients are not keen to start treatment. Because when they start treatment, the clock starts ticking again for them, and then they worry about running out of options, and so I still am fairly conservative. I tend to sit on the patients, watch the tempo, perhaps repeat imaging, look at the urine light chains. But this man presented with renal failure. So he already has a vulnerability in his nephrons, okay? And the light chains are climbing, and I would probably err on the side of treating at biochemical relapse rather than waiting for CRAB criteria, if that is the only other point at which one would treat. But it's joint decision making with the patient. But in patients who present with renal failure and have light chain disease, I have a much lower threshold for proceeding with treatment on biochemical relapse.
Yeah, I agree. I think that was a particular argument in this case. It was also seen in that paper that often patients will relapse with the same end organ damage that they have at presentation. So you really are looking out for that, whether it's renal failure or bone damage or whatever. That's what you're trying to prevent. And I guess if they didn't have any of those at presentation, maybe you'd be a little more comfortable. But
Exactly. And if they do present again with renal failure, it might limit their treatment options and tolerability.
I'm going to ask Niels what your perspective is from a Dutch angle, as it were.
Well, the Dutch perspective, I think a little bit what Qui, I think, says. I look at how the patient presented, and if it's very aggressive presentation with a lot of trouble, I also tend to start earlier. And I carefully look at the kinetics. If something is going up like a rocket, I get very nervous and I start early. When it's and sometimes it goes very slowly, and then sometimes you can wait several years, in fact. Maybe now with the bispecifics, actually, I'm a bit more on the. I like to start earlier because tumor burden is really predicting your outcomes. So if you start with 100% tumor burden, teclistamab, elranatamab will only give 30% response. If you start a little bit earlier, biochemical progression, and your tumor burden is 20%, your chance is 70 to 80%. So I always say refer these patients for trials, for treatment early on, so that we optimize the chance that these patients get a CR and then 3 years of extra life.
And actually, how about the line of relapse? So would you treat it differently at first relapse versus second relapse, third relapse? In other words, would it influence your decision to treat earlier or later, in fact?
No, I think I always look at the presentations. And you also don't want to wait until a patient has deep cytopenia, like thrombopenia, because that's very troublesome. Because if a patient has thrombocytes in the end of 50 and you have to start KRD or DARA-KD, well, the patient has to
we can't do that in the UK.
The reason I say that, though, is that if you look at a case like this, classic post-auto case, either light chains or paraprotein reappears, and actually we've seen quite a lot just on our own practice on myeloma 11 who had to stop the lenalidomide because they reached biochemical progression, so they're no longer eligible to remain on study. Stop lenalidomide, and actually some of them just sat there for another 3 years. Whereas in even sort of third or fourth relapse, you kind of know what's happened before as well. Not just what they've presented with, but you know how their relapses have behaved as well. And that's why I asked the question. It possibly influences a little bit, just from a personal experience of that individual.
But sometimes you can be totally mistaken. Maybe to comment on that, I have a patient who was 40 when he developed myeloma with spinal cord compression. He had to rehabilitate for many weeks, and in the end was able to walk and move everything as he did previously. So very aggressive, nasty presentation. So at the time of biochemical relapse, I wanted to start treatment. He was having some areas of PET positivity. He was his M protein was coming up, and I wanted to prevent again nasty stuff. But in a conversation with the patient, he didn't want to start yet. He wanted to carefully monitor. And I think we are already 5 years past by the moment that my fingers were itchy to start prescribing drugs up to a second transplant. And now 5 years later, he's coming every 2 or 3 months to my office. And his MGUS, like myeloma, has stabilized.
There's a question.
He didn't progress any further.
Sheila, question at the back.
Hi, thanks. Sheila McKinley from Myeloma UK. I just wanted to pick up on a couple of things that both Quia and Neil said, which is about patient view and actually how you approach this conversation with patients. What works, what doesn't work? Do you feel there are things you would like to know more about to better equip you to have those conversations?
Absolutely, thank you. Is there another question? No? Oh, Jam.
Sorry,
Yeah.
sorry, should we answer Sheila's question?
Yeah, it was a question. It wasn't a statement, it was a question.
Sorry, was it a question or a comment?
No, it was a question to say, how do you approach those conversations with patients, and are there things that you feel you lack, or are there things that could help you have better conversations?
So I think what Neil says is to try and understand what the patient might feel comfortable doing, and I think patients will sometimes express that quite clearly. It's very anxiety-inducing to live with the concept that you're relapsing without anybody doing anything about it for some patients. For others, the thought of going on to more intensive therapy compared to, say, single-agent lenalidomide is much more concerning, and I think that probably is all dependent on their previous experience of both their first diagnosis and potentially the toxicity of the first-line treatment they had. So knowing about those things and exploring those things with patients, I think, is important.
Can I follow on from that? So you mentioned the anxiety, the sword of Damocles that hangs over people if you monitor them. And I mean, would you tell this patient that they'd... I'm interested in what you both think. Would you use the word relapse with this patient, or would you not?
So I think in the case of this patient, and they weren't on the intervention arm of the trial, but if they had been, they'd have had to stop treatment. So you'd have had to have a conversation about relapse, and they will know that. You will be discussing with them their paraprotein. So yeah, within the context of the trial, they'd then be having an end-of-trial visit, and they would therefore know that information. Outside of a trial, I guess you would talk more generally about the changes in numbers and maybe not focus so much on the precise, what a precise number is or isn't in terms of IMWG progression. I guess I'd have less of a discussion in that setting maybe, but they'd clearly be knowing that the paraprotein was changing, and that in itself induces anxiety.
Emma, what about you? Off the context, out of a clinical trial, would you use the word relapse with the patient or not?
I mean, our patients are often so well educated now. You know, the work of the charity groups has ensured that. So many of them are really clued up, and you know, a lot of my patients will come with their notebook and want to write down their results. And you know, we may frame that conversation in the context of, you know, there are early signs that your myeloma is becoming active again, but at this moment. I was taking the Jam's name in vain, really, earlier when he was laughing at me being the person to defend waiting. And I think Niels's point is a good one. Sometimes it's about what do you think the next treatment is going to be as well, whether that's where that is going to be more effective. But because I work in the clinical trial space, sometimes I know I've got a slot on that a patient is now eligible for on a really good trial, and the standard of care option is rubbish, and that might push me. But yeah, it's it is a very individual decision.
Great.
So just so quickly, I realize now that Sheila was waiting for a response, so a quick response, Sheila. Emma touched on a good point, which is that it's important to find out what level of information and understanding the patient has as to what the choices are, what the consequences are. And often patients have an idea of treatment only from what treatment they've had and what their experience has been about treatment. So I think it's important to explore what they understand about what's available and what the relative toxicities and the balance of risk-benefit are for them from the options that are available. And that takes time. Unfortunately, time is something we don't often have in clinics. So this might be a conversation you'd have to revisit again with patients. And this is where clinical nurse specialists, well-informed clinical nurse specialists, are really so important. But thank you for raising that, Sheila.
Jam, question?
Just sorry to come back to the point of the bone marrow. I think repeating genetics is really important in this case. I just wanted to make that point, because if you saw clonal evolution, you would treat. I would certainly treat. And the other point is, if you don't see clonal evolution, you have we've all seen these very, very standard risk relapses where patients biochemically progress very slowly. I say your disease is a bit more active, and everyone's seen it, 12 months, 18 months, even 2 years. And that's their only time off treatment, because then once they're on second-line treatment, they're on therapy till they die. So I think get as much information as you can, because there is a group that you don't need to jump into second-line treatment for.
Thank you. So we have overrun a little bit, but actually some really good discussions, so thank you. So I think we'll maybe just shorten coffee a little bit to ask you to come back at 25 to, if that's okay, for the final session, please. Thank you.
Crystal Wall slide was better than
Very
mine.
good.
It's